Hi, my name is Matt Blois, and you're listening to Medically Necessary, a podcast about the healthcare supply chain. On the show, I talk with experts, business leaders, and researchers about how we get drugs, devices, and medical supplies to healthcare providers and patients. This podcast is brought to you by Ryder, the only fully integrated logistics and transportation provider in the industry. Ryder's solutions cover the entire supply chain, including warehousing, transportation logistics, e-commerce fulfillment, and last mile. Discover how Ryder can make you ever better at ryder.com. So today I'm talking with Vanderbilt University Medical Center's Chief Supply Chain Officer, Teresa Dale, about the impact of telemedicine on the healthcare supply chain. A lot of hospital systems saw telehealth visits skyrocket last year, and some providers are expecting those appointments to remain well above pre-pandemic levels. That means healthcare supply chain professionals will need to adjust. So recently, Teresa started a new company under the Vanderbilt umbrella called CareFluent Connect, which provides medical devices and equipment that patients need after a medical procedure. So a big focus of that company is making sure that patients can give their doctors feedback about whether the equipment they received is working well and whether they're using it and how that's going. But the company's focus on getting medical products to patients once they leave a hospital or a healthcare setting also offers this preview on how the healthcare supply chain might work for patients who are using telemedicine. So Teresa, thanks for joining me on the podcast. I guess to start off, can you just tell us about this company, CareFluent Connect? What does the company do, and just what's the story of that company?
So thank you, Matt, for having me on today. And I'm excited to talk to you about what Vanderbilt's doing in this space and how CareFluent Connect came about. It really was the genesis of really understanding where healthcare was going. And even in the pre-COVID era, we started to look at how there was a shift of care that was moving outside the four walls of the hospital and how hospitals were trying to accommodate for that. And I think a lot of us were thinking about telemedicine at that time. But we also were trying to expand to see what was going to happen in the ambulatory environment and how did we respond to patients and case types that were being seen in a more ambulatory setting than the traditional inpatient setting. And so in talking with physician and clinical colleagues, our colleagues in social services that are responsible for setting up those types of products and services patients need once they leave the hospital, and talking with our home health department, our company that services home health, we started to realize that there was an area of service and support that really Vanderbilt had traditionally been outsourcing to third parties. And with that outsourcing to third parties, it did not always provide us a line of sight into whether or not those services or products were meeting the patient's need, being fulfilled, whether patients' expectations were being met, whether our provider expectations were being met. And we decided that it was really time for us to take ownership of that segment of work. And so we started on this journey of standing up CareFluent Connect. And oh, by the way, COVID came along and it accelerated telemedicine and it accelerated conversations around the hospital to home. Vanderbilt opened up a COVID to home program, and now we're moving into the hospital to home space. And so it really afforded us the opportunity to all the pre-work that we did to stand up CareFluent to address patients' needs. So what are those? It could be durable medical equipment. It could be home medical equipment. It could be basic medical supplies that the home health team needs to care for a patient, either in a home health environment or in a non-traditional hospital to home type of environment. It could be some level of nutritional support. It could be a transportation requirements to get the patients either out of the hospital or get the patients from potentially their home into a clinic visit or procedure. So it really was trying to close that last mile for the patient and be able to say, we're going to take ownership of this segment of work as long as the patient wants to utilize our services. And with that, we hope that it will increase our patient satisfaction. It will increase our provider satisfaction. It will help ultimately to improve cost, quality, and outcomes. Hopefully reduce readmission rates, keep people from having to show up in the emergency department unnecessarily, hopefully decrease complication rates because they're being educated and have what they need as they're being discharged from the hospital. And then through telemedicine visits, back to your point, when a patient is seen by a provider and a need is identified, that they don't need to be admitted for, they don't need to be in a hospital or home, but maybe they need some sort of intervention. If it fits in the portfolio of services that CareFluent Connect provides, we want that provider to think of us first and be able to offer that to the patient so we can again provide those services and not rely on the patient to have to get in their car and go to a store to get something, or not have to go online and search for what it is that they need, but that we're there to actually help guide them through that process.
Yeah. So I think you mentioned, this was a project that you started thinking about this well before the coronavirus pandemic, and I think you mentioned, you were looking at this trend of healthcare moving from more of a traditional inpatient setting in the hospital to all kinds of different places. It could be sort of an outpatient clinic, it could be telemedicine, it could be a lot of different settings. So I'm wondering if you can sort of give us a sense, like, what are some of those different alternative sites of care that aren't the inpatient hospital? Like and maybe it'll be good to distinguish, what were you thinking about when you kind of started this project? What were those alternatives before COVID, and then kind of what does it look like now that the pandemic has really increased the use of telemedicine?
I think that the sites of care were the same pre as they are post COVID. It was just that pre COVID, a lot of it was theoretical,
yeah,
versus real, right? And COVID thrust us forward very, very quickly into telemedicine, and many of us into, we called it initially COVID to home because it was COVID patients with lower acuity that could be cared for by nurse practitioners and home health care nurses in their home environment versus having to admit them and take a bed for a higher acuity level patient that had to be in the hospital. But we envisioned that, with the demographics of folks changing, and younger individuals, really wanting to avoid hospitalization if possible and wanting to seek care through those virtual types of visits and have that experience and be in their home more than they would choose to be in a hospital. We really started thinking that the whole shift in the requirement of the consumer market was going to change, and that it was going to be eventually to a point where those who came into the hospital really, really needed to be there, and those who really didn't need to be there were going to seek those alternatives either through telemedicine or in an ambulatory type environment. We also saw, with some of the reimbursement and the shift in changes for, say, total joints. You always had to be in a hospital and have a total joint. Now those are being done on an ambulatory outpatient type of basis. Some of the minimally invasive spine surgeries. But again, those patients all require a level of post-op needs for products and services, whether it was inpatient or now in the ambulatory setting. So I think what COVID did was accelerate our vision of what we thought was coming, what the payers were going to look for, what the consumer was going to look for. And so again, it just, we happened, better lucky than good sometimes. We got the pre-work done and out of the way that allowed us to be in the position we are in today.
Yeah, and that's right. Well, and that's exactly the next thing I was going to ask you about is this was something that you started working on a few years ago. Like you said, then the pandemic happened. That you had kind of done a lot of this pre-work already, and I mean you were already starting to address this in the answer you just gave. But I'm wondering, how did the coronavirus change or not change the plan for CareFluent Connect? Like, did it? I mean, is it? Like you said, it's accelerating some of the stuff that you were already seeing. People were already starting to get treatment outside of inpatient hospitals and things like that. But I guess could you just give me a little more, help me understand, how did the coronavirus pandemic change your vision for the company?
I think what it did was it highlighted the vision of the company to the end users. So, when you introduce a concept like this and your end users, and I'm talking in particular here, the clinical end users, the physicians, the social workers, the nurses, nurse practitioners, they're used to a business as usual, using the same providers that they had been using, third parties that they had been using. And so we've been talking about this, and we've done a ton of interviews and got people excited about it. And we actually, as we've been going through this journey, publish on a monthly basis a kind of a current state of where the company's at as we've been moving along to keep people excited and involved in knowing what was coming. But I think what COVID did was actually people were calling us saying, hey, are you ready yet? Can you do this? We think would be a great idea for CareFluent Connect. Can we sit and talk to you about this? And so I really think what COVID did was it helped us to accelerate what we're hoping is the adoption of the service platform in a much broader way than what we had anticipated.
Yeah, that's an interesting thing to think about, because it is, you can have a great idea, but if people aren't ready to adopt it, then it's not going to go very far. And I think over the last year, people just, healthcare has changed so much. The way people think about it is people had to have these pretty significant shifts, and things just moved a lot faster than they would have in normal years. And so that's interesting to think about how that affects adoption. And so I guess generally, you've lived through this year. You've been working on this company for a long time. Just a general question, like how do you think the growth of telemedicine over the last year has affected the healthcare supply chain?
I think it has forced us, or it should force us, to be thinking differently. And I would say telemedicine, COVID, whatever the impetus is behind the change, supply chain in healthcare needs to change. And we were very comfortable with the models that we had in place and almost complicit with some of those models. And I think this experience has given us the ability to look at our business differently and challenge ourselves to seek alternative ways to fill a void and a need and not be 100% reliant on third parties. I mean, there are certain things where you always have to make a financial decision on whether you're going to buy or build, right? You have to go through the analytics of doing that. But sometimes when you do those risk benefits, if you're going to build and it may cost you a little bit more, the downstream pickup from that, you might not be able to put a price tag on it right away, but over a period of time, if you have the right measurements in place, I think you could go back and say there was actually value here that we weren't anticipating. An example of that is I truly do believe that if we can close this loop, just say with durable medical equipment, and be able to educate the patient, hands-on experience, face-to-face experience versus them getting things through the mail and watch a video on how to use this, and then be able to have a number that they call and they give feedback, and we can have ongoing conversation and close the loop in their medical records with the physicians so they know what's going on. We really do believe that it should decrease complication rates, should increase their compliance with their medical care plan, should decrease readmission rates over time. And we've got to prove that, right? But you have to inherently believe that if you have that personal touch versus just a transaction that occurs with that patient through a third party, that it's going to lead to some of the outcomes that we're thinking about.
Yeah. So I think right at the beginning of that answer, you said, that the healthcare supply chain had to change. And I think you hinted at a couple of the things that you felt like needed to change or had to change within the healthcare supply chain. So, I mean, what are the things that you felt like had to change that we know now had to change?
So I do believe I'm a little bit on a soapbox right now about this one. So with our supplier partners, I think what COVID has shown us is that there needs to be more transparency across the global supply chain for us. We have great relationships and have some longstanding partners that have been in the industry that we've worked with well, but we are at risk. There's never been. We've always looked at the supplier provider relationship is, give me the lowest cost kind of thing, without really understanding um, sort of the profile of that manufacturer and the risk associated with making the decision outside of price, right? And so I do believe there is a challenge that needs to be put forward to our manufacturing partners around transparency of where they're sourcing raw materials from, where their manufacturing plants are, what redundancies they have in place to make sure that that their customers are covered. I mean, this pandemic, this was a global crisis for supply chain, and it showed all of the weak links that are there and how much we really don't know about what is going on with products in manufacturing before they actually hit our warehouses and come into our buildings. And so I do believe that this is a call to awaken for folks to say, we need to be more open with one another. And if you're willing to share that information with me, I'm willing to partner with you and give you my book of business, right, to do that. But those who aren't willing to have those conversations and really look at this through a different lens, then we need to be thinking about alternative sources for those different product lines.
Yeah, yeah. I feel like that's a sort of transparency is a refrain that I've heard from a lot of people over the last couple of months, and really, just people are realizing how valuable that is, and how that influences the supply chain. I wanted to kind of steer back towards telemedicine, though, just to go back to that, because I think one of the things that you mentioned is one of the really big changes in the supply chain. Just sort of it feels like a lot of people are putting a bigger emphasis on resiliency, even, there's like that balance of resiliency versus cost. And I think the pandemic has caused some people to reevaluate, what the right way to handle that is. But then the other, one of the other big shifts has been just this increase in telemedicine, accelerating that trend you already mentioned of just people getting care outside of an inpatient hospital. That might be ambulatory center, it might be in the house. And so I'm just wondering from a supply chain perspective, what is different about supplying somebody who's a patient via telemedicine versus a patient who is not a telemedicine patient? Like, what are the challenges? Well, and I remember, I think we talked I think last week or 2 weeks ago. And I think one of the things you mentioned that I think it was Careful and Connect was doing, or Vanderbilt was doing in general, was you were putting together some sort of packages. There were sort of packages that you were putting together, I think, for COVID patients, saying, we've got somebody who's a telemedicine patient who has COVID, and we're going to send out this package with these supplies. So I think maybe can we start. I've said too much now, but let's go back to my original question, which was what's different? What are the supply challenges? What are the supply chain challenges that are inherent for the telemedicine situation that aren't present if it's a patient who's in person?
All right, so if you think about, and this is just Teresa Dale's version of this, right? So if you think about telemedicine, I know one of the big areas where telemedicine has been utilized in our organization is behavioral health. So there really are no supply chain there. So that is really not an area that we need to think about. But there are other clinic type of appointments, and that's really what is occurring. It's those clinic appointments where people weren't physically coming into a clinic to be seen for their doctor's appointment, where they're doing a telemedicine virtual appointment there. So say somebody is a post-op surgical patient and they have a telemedicine visit with their surgeon, and the surgeon says, I really think that you need X, Y, or Z, or we need to get home health there. Well, our goal is that we'll be supplying home health with the supplies that they need. Right now, they're using a third party, and we've got to work through all the regulatory and the billing components of that, and what's the reimbursement, et cetera. But whether it was our home health going and we're giving home health the supplies and then they're going into the home and taking care of the patient, or if they don't need a home health visit, but they need, say, they're seen for COPD and the physician says, I really need to put you on an oxygen concentrator and I'm going to prescribe oxygen for you. And, um, and he writes an order, which then is home medical equipment. That order could then come to CareFluent Connect. We could fill that, contact the patient, do all of the pre-auth and all of that, then fill the order, go to the patient's home, educate them on that, and it's done and taken care of. We document that back into the medical record. So that's how we kind of see telemedicine working, is that if it requires some type of equipment or supply and they're in the physicians in the clinic versus them putting it on the patient to go and figure that out. Um, or trying to go through a list of 16 or 20 different DME providers, that we have a centralized, and we're going to use a technology solution to do this, that not only has CareFluent as an option, but we're going to list a couple others, 2 or 3 others as well too, that have shown that they are meeting our quality needs for our patients, right? They're good providers, they're responsive, et cetera, and allow this to be done electronically by the provider versus all the paperwork and the telephone calls and all that sort of thing that have occurred in the past. So we need to automate our processes to make sure that we're caught up with the telemedicine, the virtual visit processes, to make it easier on the provider and then easier on the patient. And that's what we're working on doing now.
Yeah. Yeah, I think that makes a lot of sense. And it's interesting you mentioned, sort of automating processes too, because it's, when I think about the healthcare supply chain, I think, all the way from making a product or making a drug, and then I think of the end of the supply chain as the patient. And it's really interesting to think about that very last final step. Like even a patient's made it to a clinic appointment, and a doctor said, okay, this is what you need. We're going to get it for you. But like you said, like if there's even just the process of figuring out, okay, where do I buy that thing? There's paperwork to figure out, and those even those very, very final things that are sort of process steps, not necessarily like putting something on a truck. Just it's interesting to think about how that can disrupt the very last part of the supply chain there. Exactly. It sounds like that's one of the things you want to focus on, is sort of make sure that doesn't happen. So I also want to look a little bit into the future now, and we've gone through this pandemic. Hopefully things are getting better. The vaccines seem to be rolling out. People I know are getting them. So I'm wondering how long, are the changes that we saw during the pandemic, are those going to be, when it comes to supply chain, when it comes to telemedicine, are those going to be things that stick around for a long time, or is this something that we're going to switch back to the way we used to do it?
So, I'll just say from the Vanderbilt experience, our numbers for telemedicine right now are not nearly as high as they were in that April, May, June timeframe, right, when everything was sort of shut down. But they definitely haven't gone back to the bottom line where they were pre-COVID. And I do believe there's a segment of the population that will continue to want to do telemedicine. And there's a segment where it makes perfect sense. And I know our focus is to grow it in those areas and really try and make it as convenient as possible for our patients and have our providers be available for the telemedicine versus kind of going back to the traditional type of operations that we had in the past. So I don't see it going away. I see a lot of organizations focusing on the future. I think we have to be cognizant of what the reimbursement and what it's going to look like post emergency acts being in place. And I think there's a lot of ears to the ground paying attention to that. And I think as long as there is support from the federal and the government and the payers, to really move the dime on how we've been providing care and make these alternative cares feasible and for everybody and right for everybody, then I don't see a reason why organizations would revert back.
Yeah, although I think it's also, like you point out, there's a lot of different sort of pieces to the puzzle, and the regulatory pieces and and reimbursement pieces are kind of a big part of that. I can imagine for, if that changes, that'll be quite different. So I like to end my newsletter a lot of times with the section that I call wishful thinking. And basically I give sources or readers or anybody who's sort of aligned with the newsletter, I give them one wish to improve the healthcare supply chain. No limits. You have a magic wand. So I'd be interested to know, if you had that one wish, what would you want to change about the healthcare supply chain?
My one wish would be that across the healthcare supply chain, there is a recognition how important being clinically integrated and aligned with your clinical colleagues on what they are trying to achieve and what your health system is trying to achieve to take care of our patients. I'm an ICU nurse by background. Everything I have done my entire career is about the patient in the bed. And we cannot afford to be transactional and functioning in silos outside of what our clinical colleagues are trying to achieve. And so that's my one wish, is that we deeply integrate into our health systems and into the care plans and show the value that I know supply chain can bring to the table.
Yeah, I think that's a great wish, and I forgot to mention that in your intro, but yeah, I think that background you have as an ICU nurse is a really interesting perspective to bring to the supply chain. Well, that's it for me, Teresa. So thanks so much for joining me on the podcast. I thought this was a great conversation. Thanks so much.
Matt,
Hope you have a good day.